welcome to the third session in our Cancer COVID-19 Recovery series of webinars. Today we're going to be talking about waiting list sizes and best practice cancer pathways. And to do this, we're actually going to be using the core model to illustrate this in practice in some diagnostic services. So with me today, we have Ben Douglas and Daniel Whitehead from the Elective Care Improvement Support Team, and also myself, Ash Mahanti, from the Demand and Capacity Team. A very quick overview of the series and what we've covered so far and what we will be covering next week. So this is a short series of webinars, which is a collaboration between the Demand and Capacity Team and the Elective Care Improvement Support Team. This is talking about demand and capacity modelling to support service planning for cancer services in the current environment. In week one, we started off with a session on getting started in your demand and capacity journey. So this was talking about the high level principles of demand and capacity planning and was targeted at folks who are either getting started in their demand capacity journey or are early on in that phase. Week two, we built on this and we talked about how the core model could be used to support the achievement of the faster diagnosis standard, so the 28-day wait standard for diagnostic services in the context of 2-week wait. And we also talked about how the core model could be used to account for different ways of working, considering factors around COVID-19. Today, we're going to be walking through some diagnostic models and focusing on waiting list sizes and best practice cancer pathways. And next week, we're going to be wrapping up the series rather, with a session on rapid modelling of endoscopy services. And this is focusing on some work that's been done in the London region. I'd just like to highlight that in today's session, we are going to be going into great detail around the principles and basic concepts. So if you'd like to learn more about those, I would like to signpost you to these sessions in week one and week two. So without further ado, I'd now like to hand over to Ben.
Thanks, Ash. Okay, a quick overview for the session then. So we're going to spend a little bit of time talking about the context that we find ourselves in at the moment, particularly around post-COVID-19. So we'll talk about some of the key things to consider when modelling diagnostics. And then we're going to run through an MRI model that is a live model that we've used to support an organisation recently. We'll talk a little bit about endoscopy. We'll just touch on that. Daniel's going to talk about modelling some reporting, and then we'll talk about how this links back to planning cancer services. Okay, so the context. We would be remiss if we didn't talk about COVID. And I think really one of the biggest changes that's happened since COVID-19, well, the two I'll focus on is firstly the size of the backlog and the impact that that's having on demand and capacity modelling. So obviously, since COVID's happened, backlog waiting lists have grown exponentially. So the impact that that's having, and then secondly, there's also a knock-on impact on the throughput for many services. So particularly around the length of time for turnaround between scans, for example, in MRI and CT, and the impact that that's had on your capacity. We'll also talk a little bit about best practice pathways. Before COVID happened, this was kind of the main focus at the moment around demand and capacity modelling in diagnostics and helping trusts set themselves up for that 28-day faster diagnosis standard and starting to meet some of the timed pathways that exist in colorectal, lung, and prostate and upper GI. And then linked kind of to that first point, we'll talk a bit about sustainable waiting list sizes and what we can do using the demand and capacity models to get an idea of what your sustainable waiting list size is and how you can bring your how much additional capacity you need in order to bring your sustainable waiting list down to the right level. So over to you.
Thanks very much, Ben. Just want to go through a couple of things here. Although that we're primarily in this modelling looking at diagnostics, and obviously it's around how to support modelling for cancer services, a lot of the principles that we're seeing here are the same principles that you would use if you were modelling outpatients, or whether you're modelling theatre capacity or follow-up capacity. So a lot of these things shouldn't be new to you guys, but there's a couple of key points that we just want to highlight. Firstly, obviously with cancer services, you need to model the whole service. The endoscopy point of view, for you doing colonoscopy, that's only just part of the endoscopy service. And, you know, the treatment side of it for general surgery and colorectal, that's only a small part of it. So you can't just model those bits in isolation. You need to model the whole service to understand the full demand within that section. So that's the first thing kind of want to mention around it. The other thing with all of these models is around having the right level of information. So, you know, a planning meeting or a couple of planning meetings beforehand is really, really key to see, you know, what information do we want? What's the data spec of what we need to demonstrate what we want? And we'll touch on it further in the presentation, but we have a guide around an intensity. So there is, you know, a low, medium, high intensity of the modelling. And with all the modelling, the greater the intensity, the greater the resource and time needed to complete it, but the greater the output of the model. So the low intensity is kind of a quick, you know, very sort of broad strokes calculation, but, you know, doesn't necessarily give you the most accurate output. So that's really important. The other thing is around choosing the currency. I mean, if you're doing outpatients, then obviously you've got GP new referrals, you've got e-referrals, so you know what you're counting. You know, follow-ups you're counting, you know, outcomes from clinic. But choose your currency when doing diagnostics. You can have minutes, you can have points, you can have patients, or you can have slots. And obviously the different diagnostic modalities will have different things. So, you know, points for an endoscopy, but you could be using minutes for MRI and CT. So it's really key to choose your currency, but then also make sure that you use that currency throughout the model. So if you're doing minutes and patients, make sure that you're doing the same for capacity and you are same for demand, and the model will help you there. But there's no reason that once you've completed the model and you've got the output in minutes, that you can't then convert it back. So once you've got that basic information that says you are short X amount of minutes, you can quite easily, using the information on the model, convert it back and then say it's this amount of minutes, which equates to either this resource, this number of scanners, this number of consultant sessions, etc. So make sure that you do pick your currency correct. And again, looking at what you are counting as demand. So I mentioned around outpatients, you would use an e-referral. So within this, what is it you're going to count as demand? Is it going to be requests coming into the service? And if it is, are these requests going to be counted as the pre-vetting or approved requests? Now, either of those are acceptable and either of those can be used in the model. There's just slight differences in how you complete the model in further stages around the parameters section. So, for example, if you're going for approved requests, then there's certain elements that will be different within the parameters section because they're not going to have sort of rot removals other than treatment, because you've already allowed for that you're going for approved requests and the rejected ones have already been taken out. So it's just a different way of filtering it. But make sure that when you start, you have an idea of what you're going to be counting and actually then what knock-on effect that has around the parameters page. The other thing that we want to mention is more so than ever in a lot of the other models, there is the ability to use historical activity to cross-check what you've done. So normally we look at models of looking at the triangulation between activity versus demand and waiting lists. So, you know, if demand's going up and activity is going down, you should have an increase in waiting list. But one way of triangulating this, and it's on the parameters page, and Ben will go through it when he does the modeling, is that you can put your historical activity for the same period that you've modeled using your demand data, and then using the information, the algorithm, the flow that's there, it will reverse engineer to say, yes, what you've got is within the ballpark figures of what we'd expect to see, or no, that doesn't kind of work. So it gives you that ability to sense check. So it's really important that you can get that historical data. The other thing that's really, really key is that obviously, especially within diagnostics, the actual machine time, the room time, the diagnostic time is only a part of what is needed to deliver that turnaround time. Reporting as well. So it's worth considering doing a separate model for reporting, or incorporating reporting time within the times allotted at the beginning if you're going to use time as your currency. But don't forget about the reporting, because you might model the machine, you might model the room, and you might find you're okay there. But actually, if you've looked at doing a pathway analyzer and your turnaround time from request to report is slow and it's the reporting part, then you need to make sure you've got enough capacity within the reporting section. So it's really key to make sure that that's incorporated as well. And back to you, Ben.
Ben, you may be on mute.
Thank you. Yes, I was on mute. Sorry, I was just saying. I just wanted to double check that the model is actually now on your screen. Is that, can you see it? Yeah. Okay. Great. Okay, so this is the first page. What I'm going to do now is just walk through this model. This is the first page that you'll come to when you're setting up your model. And this is an MRI model that we've done at a large organisation. It was pre-COVID, I will say that, but this is how we set up the model. I will say that this is not the only way to do this. This is just how we did it on this occasion. But essentially what we've done is split the service up into 7 modalities here, and we've split that by the length of scan time. So we've done it from 20-minute MRIs right through to 120 minutes. You can do as many of these as you want, so you can use more or less, and you just change that by this drop-down box here. So if you wanted 9, you could put 9 in there, no problem. And then what we've done here is listed the size of the waiting list, so as in how many patients are waiting for each of these scans or scan slot times. We've then further broken everything down by whether the patient is on a 2-week wait pathway, whether they're on a routine pathway, which would be a 6-week wait, or are they an acute. So this is for patients who've come through A&E or are currently inpatients within the hospital. And then the other bit on this page, which is important just to note, is the unit of work that. So this is the currency that we keep talking about now. Here, there's a drop-down box, and you can switch between patients, minutes, or points. Obviously, we're doing radiology, so we've decided to use minutes for our purposes. That was the currency that kind of ran throughout all of diagnostics. Now you can use patients, and if you're doing endoscopy, for example, you would select points at this stage. But yeah, we're using minutes. The other thing just to bear in mind here is there's a question here about planned activity. Now it'll say, do you want to include planned activity or within your model? And I would say for MRI, you definitely want to click yes to that. And what that does is it opens up the planned tab, which is along the bottom here. And the reason that's important is because for an MRI service, there is quite a large proportion of capacity that will be taken up by patients who are waiting for surveillance scans, who aren't on an active waiting list, like a PTL, a ticking clock essentially, and they'll be on the planned waiting list. But that still has to be taken into account when doing the demanding capacity. Moving on to the next tab, this is the demand tab. Now you can go back 5 years here. Now this is historic demand. And what we've done is we've split the historic demand into the categories that we selected on the previous page. So you can see that we've got 20-minute, 30-minute, 40-minute, 50-minute MRI slots. And then again, those further subcategories of 2-week waits, routines, and acute. So this is going back a couple of years, and it's saying how many patients did we have over the last 3 years who were waiting for a 30-minute scan time, and how many of those were on a 2-week wait, how many were on routine and acute. and we've gone back on a week by week basis. So we've gone back quite a long way. Now this data is normally provided by the information team within a hospital. This is a report that needs to be generated from the back end of your systems. It can take a while to get it right, and there will be some refining of that data that will be required. But essentially, this is a task for your information team. Okay, I will move on. And what that does is it provides, when you click onto the next tab here, it provides that information in SPC format. So you can see over time what the trends are in relation to demand that's coming through the service, where the peaks and the troughs are. And crucially, it also puts it into SPC format. So you can get the upper and lower control limits that allow you to see if there's anything outside of those control limits would indicate that something particularly extraordinary has happened. That's called special cause variation. But crucially, what it gives you here is the 85th and the 65th percentile of your demand. So when we're thinking about demand and capacity modeling, there's a temptation there to say, well, if on average, i.e. the 50th percentile of demand, on average we get, I don't know, 20 patients a day, then we would need to have capacity for 20 patients a day. But it doesn't work in reality like that. And what we are always advocated for is that you set your capacity at between the 65th and the 85th percentile of demand. And what that means is that 65% of the time or 85% of the time, you'll have enough capacity. If you set your capacity at the 50th percentile, by default, that means that half of the time you're not going to have enough capacity, and that will have an adverse effect on your backlog. Similarly, a very similar story with a planned waiting list. So you would put planned activity in here, and you can do either. It's only 52 weeks, not up to 5 years. So you're only putting one year's worth of data in here, but it can be either historic or forward-looking, and that really depends on how good the data is in your systems. Now, for this organisation, we put a retrospective view in, because that was far more accurate than what they could do from a forward look to see what was planned for their scanners going forward. So this is 52 weeks worth of activity that went through a planned patient and using the same category, so the 40-minute, 50, 60, 70-minute scans as before. And that gives you, again, it gives you it in SPC format, so you can see the patterns over time about what's happening with your planned waiting list. The next key tab to talk about is the capacity tab. Now, this is a task really for your operational managers. This is the people who run the service day in, day out, who will be able to answer the questions down here. But essentially, this is split into two parts. There on the left-hand side, there is the capacity, your core capacity in blue here, and on the right-hand side, this is where you list out all your ad hoc capacity. The core capacity is basically split down by the scanners that you have, the session times that you run, when they run from and to. So this organisation, they run 8 till 8. This one's an important one. How many weeks a year do these scanners run for? Now, a word of caution here, don't overestimate what this is. It's important to get this right. And if you need to, go back and check how many weeks per year those scanners ran for last year. It's almost always less than you think it's going to be. So if you put 52 weeks of the year there and they don't run 52 weeks of the year, your model will have a skewed output. And often it boils down to that you've overestimated your capacity by overestimating how many weeks of the year they run. That then provides you with your average minutes per clinic, and that is also aggregated up over the course of a year. On the ad hoc side, this is where you list anything that is not routinely available, booked capacity for that organisation. So, for example, this trust have used the mobile van that they get. They've also got some access to a research scanner, and they've also got a bit of access to a university scanner as well. If you have a large number of patients that are seen through ad hoc sessions that you put on in evenings or weekends that you have to recruit additional members of staff for, pay agency or bank to do it, and that needs to be in the ad hoc section here. Okay, the next page I'm going to talk about is the parameters page. So what this is it basically takes that core demand that's coming through that you've listed on your demand sheet there. And then they say, okay, once you've got that demand coming through, there are a number of things that can happen that mean that the patient doesn't actually get the scan at the end of the day. That can be that they might DNA, they might cancel, or they might drop off the waiting list for another reason, such as they are admitted to hospital and therefore they have their scan as an inpatient, or they decide not to have treatment anymore. There could be many reasons why that might happen. So those three broad areas are accounted for here. So all of your DNAs and cancellations will be loaded in here, and also those ROT patients, that stands for removals other than treatment, would go in here. Now, what you put in for your ROT will completely depend on whether in your demand you've taken a number of pure referrals, or whether you've taken the vetted demand. So if often what will happen is a consultant in clinic will say it needs an MRI, that referral will then go to the radiology department and they will vet it and they will either accept or reject it. If you're putting the demand data in from before that triage process, then you will have a much higher ROT rate here than if you're doing it after. So if, as you can see on this model, the ROT rate is about 0, and that is because this number here has been is the number of patients after they've been vetted. So all that ROT has been taken out before. There's no right or wrong way of doing it. You can either do it before or after. It doesn't matter, but just make sure that you don't double count it. And then at the end, that will kind of spew out a number of what your true demand is, not what your total kind of raw demand. This was almost like your net demand. There's an important cross-check that Daniel mentioned earlier that we can employ here, and it's this function here that basically compares this expected attendances with how many attendances did you have for the same period last year. And what that basically does is say, to use this as an example, it says this model is saying you can expect to have 32,000 minutes worth of activity going forward. But if you put in here, well, actually, last year we delivered only 22,000 minutes. It's saying something has to be wrong here, because what you're significantly under last year what you're saying you will be for this year. So that means that that something has gone wrong in this page, and the likelihood is that you've underestimated some of your ROT, or your removals other than treatment, or some of your cancellations of DNAs, and that this number is actually lower in real life than what this is suggesting. And it works the other way around. If your activity last year is much higher than this is predicting, then obviously the same warning sign appears. And so that's quite a useful cross-check to have in place. And then the final tab that I'll just talk about is the summary tab. So this is basically pulling all of the information from the model and kind of spits out the output on this page. And ultimately, what this is saying here is the blue bar here is the 65th to the 85th percentile of demand. So this model is saying you need your capacity to be within this range. But what it's actually showing is that your core capacity, demonstrated by this cross, is actually less than you there's a small rectangle within that blue triangle, which is your capacity, which is your core and your ad hoc. And what that is basically saying is once you factor in ad hoc, you're there or thereabouts just got enough. So the takeaway message from this is that this organization is very reliant on ad hoc capacity. And that's often expensive, it's often delivered late in the day, it's often requires a lot of management time to organize it and to staff it. And so there is an argument to be made here that if you could make that ad hoc capacity core capacity, the service would run a lot more smoothly, and you'd have a lot more kind of certainty around the demand, the capacity you have available to you. The final thing I just wanted to point to here is this sustainable waiting list size. And I think, we've mentioned it a couple of times now, and this is particularly important now that we've gone through COVID-19. So again, what what this green bar is showing you is the sustainable range of your waiting list. So what do you want your waiting list to be roughly within this range, given the size of the service? And what it's actually showing is this diamond here showing you the current waiting list size, and what it's showing you is that the waiting list is too big for the service. You can then use this function here that says, okay, if I want to bring that waiting list down to a sustainable size, and that will help me meet some of those waiting times targets around 6-week waits, or around getting patients in for a 2-week wait scan. How quickly do I want to bring that backlog down? So I've put 6 weeks in here, and then it'll tell you at the bottom how many additional minutes capacity you need to factor in order to achieve that. And you can change this, you can play with it. So you can make it 4 if you wanted, and that will change this number accordingly. Or you could even make it larger there, and it'll change it again. So you can have a conversation with other colleagues within your organisation to say, okay, we need to bring this waiting list down. We're going to do it over 2, 3, 4 months, and this is how many additional minutes of capacity we need to provide in order to deliver that. And that is a part of the planning function there that you can use. There is one last thing that I just wanted to mention, which is if, like we are doing here, you are factoring in some elective patients and some acute patients, you have to ensure that you're comparing apples and apples. So if patients are being scanned out of hours, particularly under this acute section, if they come into A&E out of hours, then what we've done, how we've accounted for that here, is that we've actually removed any acute scans that happen out of hours from the demand figures. And the reason for that is because we can't put out of hours capacity into the capacity tab, because in many instances, or in most instances, any out of hours capacity will be by definition underutilized. So if you put that capacity in here, it will make your overall service look very underutilized, and that's not a fair reflection. So what we've done is we've just removed any out of hours scans from the demand figures, and we've also not included any out of hours capacity. So you're doing a like for like comparison of demand and capacity within hours. And I think it's important just to mention that. Okay, so that is the whistle-stop tour of how we've set up the demand and capacity model for diagnostics. What I'm going to do now is I'm just going to flick back to, I'm going to stop sharing that screen and flick back to the slides, and I will hand you back to Daniel.
Thanks, Ben. So one of the things that we advocate, or we do when we go to support a trust, is not do demand and capacity in isolation. Obviously, we've mentioned before around when looking at a service, especially with cancer services, that they are made up from key parts in other services. So what we would look to do is we would look to model the pathway, have a look at the pathway. And we've got a tool for that, which is called the Pathway Analyzer. At the end of this presentation, there's a link to our Futures platform, and you'll find links on that platform to the analyzer. Some of you may have used it, some of you may know about it. And basically what we're doing is we're looking at milestones, key milestones along a pathway, timed milestones, and then we're taking actual activity data, plugging that into the model to say, did you meet the milestone? Were you under the milestone? Were you over the milestone? How does it look? And what that does is that kind of gives you your starter for 10 for certain areas to look at. So not just the normal areas around, outpatient activity, follow-up appointment, following a diagnostic, but as we mentioned, reporting time. Is there a delay in your reporting time? Is there a delay in the histopathology being returned after being sent off from a diagnostic? And it gives you an idea where to face and where to focus the demand and capacity modelling within that cancer pathway. So we know for 4 of the services that they've already best practice national pathways around the 28-day faster diagnostic service. So you've got colorectal, you've got prostate, you've got lung. Some trusts have already started to devise their own 28 days and timed milestones, but it gives you that ability to use the demand and capacity model. And, focusing on 28-day, you can use the pathway parameters section around how many days to first, how many days to urgent, how many days for a 2-week. That part, that can help you model around achieving 28-day. But what we would always do is do a pathway analyzer to highlight the areas that you want to go in. So, for example, if you're looking to maybe go to straight to test or set up a one-stop shop or look to carve out dedicated cancer capacity for patients, you can look at the pathway in its entirety, see where the blockers are, then do the demand and capacity modeling in combination, and then you've got a really robust output for them building your business case or taking to your cancer board or to your exec board to sit there and say, look, we've highlighted where the delays are, we've looked at the capacity and demand, and this is what we've found. And as you can see from the two models on the screen, you've got the top one, which was just a colonoscopy, and you can see, so 30 patients that went through the modelling, majority of the pathway, they're hitting all their milestones, but they come to the end and the delays in the histo reporting returned. And also there's the delays in that they are telling the patients if they're benign, but there's no evidence they're telling it. The process at this trust is that they have a letter, a stamp that's recorded on the system that they've actually informed the patient that they're benign. And what happens is they're having that conversation with the patient, but they're not recording the data, so it can't be corrected. And that's where you see the sporadic red. The rest of it, they're under the milestones. But being under the milestones can be just as damaging as being over the milestones, because if you're allowing too much time, it has knock-on effects to capacity and demand. You could be using it in a better way. And actually, you want to keep those milestones as close to reality, but you want them to be a sort of achievable challenge. You don't want to over-egg them, because then you're just underutilizing everything. If you look at the bottom one, you can see that that's got issues all along the pathway. There's only a couple of areas where the majority of it is green, so they would be okay, but there isn't one specific area along the pathway that needs to be dealt with. There are several different areas, and what you could then do is then look to model those specific ones. So you've got MRI request delay coming there. So why is there a delay there? Is there enough admin capacity? You can start using these models for a lot of things, but I guess kind of what we're advocating on this one is, especially with the cancer services, because it's made up of multiple different areas, is that it's really worth doing that pathway linking in to then determine where to do your capacity and demand modelling. Thank you. Back to you. No, that's me. Sorry. So just to mention that we said at the beginning around an intensity scale and around modelling follow-ups. There's a couple of resources which are available on our platform, and we've got kind of indications and links to them here on the presentation. So demand and capacity intensity scale. This is just to support what we said earlier around the different intensities. So low intensity would be, for example, using new to follow-up ratio, making some adjustments because of ROT, and then that gives you a broad strokes. Problem around that is that you're using activity to drive theoretical demand and capacity, when actually activity is what you've done, not what you should do or what you can do. But that's a quick way of coming up with an output. Then you've got the medium intensity, which uses more actual data, and then obviously you've got a high complex intensity, and these can be set and determined by what you're trying to model, what you think the output might be. If you think something's going to be great, you could do the low intensity first, and then if it turns out that you have got problems, you can always then go and do a high intensity. It's around the resources you've got, but it's also around the output that you want. So if you're trying to build something and you need a much bigger, robust output, then obviously it's always better to go for the high intensity. However, you could be hampered that the availability of the data isn't quite there. There's some trust, and there's one that I've supported, that when going in to do endoscopy, we couldn't break it down by the individual modalities. So we could do endoscopy as a whole, but if you've ever tried to do any modelling around a service where there's a lot of subspecialisation, that might sit there and say there's enough capacity in general, but there isn't enough in a specific area. So if you haven't got that data availability to model it in a certain way, this guide will help you determine which is the most sort of useful way for you to do it. And then there's a secondary one, which is the follow-up model. It's just 3 or 4 slides, but obviously there's often a lot of questions around modeling follow-ups. As we said earlier, it's easier doing new, or it may be actually easier doing sometimes diagnostics, because there's an actual request or an order that has to be raised on the system. Capturing follow-ups isn't as robust in everywhere they've been, and it just gives you an idea of what's a good way to approach modeling follow-ups. There's also our link there to our futures platform, where these and many other documents, as I mentioned, the pathway analyzers there, and there's some other really good tools around looking at post-recovery after COVID-19. There's our general email address there, so if you want to drop us a line if you've got any problems, but do, you know, become a member of our platform. You don't need to be approved. If you're already a member of the futures homepage, then just join our platform, and then there's some things there which should really help you in delivering your work.
Thank you very much for that, Daniel, and thank you very much for going through the model, Ben. So just like to again recap that we will be finishing off this series next week. So please do join us if you'd like to see our final session on rapid modelling of endoscopy services to support service recovery. And this is looking at a case study done in London. The links to join these sessions are available in the slide deck. Also, we talked about the previous sessions that we ran, so details of those are in one of the earlier slides, and the recordings will be available on the Future NHS platform. So I'd like to now wrap this up and move on to the final slide. So I'd like to, first of all, thank you for watching this webinar today, this recording, and hope this has been of some use. I'd also like to reiterate what Dan actually talked about in terms of actually looking at pathways. So demand and capacity is one part of this exercise, but it's also very important to actually look at your pathways, look at your processes and map all of that out, look at the timings. We talked in a little bit more detail about this in the first webinar, and have actually got some additional resources which would actually complement the pathway analyzers. So if you'd like to look into that, feel free to refer to the resources in webinar 1. Again, it is about a collaborative exercise, demand capacity in isolation, pathway mapping in isolation, working in isolation, not having the right people in the right room, that doesn't work. So make sure you get that right. So do visit us on our website if you'd like to learn more about what we can offer, some of the resources that we have, some of the tools that we have available for you. Do feel free to sign up to our bulletin if you'd like to be kept abreast in any developments in the demand and capacity world. And do also feel free to join us on our Futures NHS platform. The link is over there. There are some additional resources, and as I have mentioned, recordings of the previous sessions, as well as some other series that we've ran previously. They're all available on there. We also have a presence on social media. If you're on Twitter, you can follow our program lead, Sandra, and she does actually pop updates now and again. So if you're into social media, just click follow. So thank you very much again, and enjoy the rest of your day.
Thank you. Goodbye.